This conference will now be
It
recorded.
took a while. All right, everybody. Good evening. This is AnCan's virtual chat support group for the low and intermediate risk prostate cancer. Today is Monday, the 25th of May. And I'd like to welcome our first-time visitor and our regular participants. Tonight, I'll be your lead moderator. My name is Bill Franklin. I'll be joined by Stuart Jordan and Rick Davis. And we may have another moderator on here shortly. We'll have to wait and see if he shows up. So this is a peer-to-peer support group, and one thing we do tell you is that we are not doctors and we do not give medical advice. Anything we discuss in this group is from our personal experience as a peer experiencing prostate cancer like you do. So if we'll answer your questions, if you information we give you, you should definitely discuss with your own doctors. So before we get into the meeting in itself, I'd like to thank the sponsors that we have that have made this meeting possible. So our current sponsors are Novartis, Blue Earth Diagnostics, and Foundation Medicine. So we have multiple prostate cancer groups at AnCan. We have a group that focuses on lower and intermediate, which you are in. We have an active surveillance group, which some of you told me you've been to. We have an advanced high-risk group that hopefully none of you ever have to join. We have a group for men under 60, and we have a gay and bi men's group, as well as a group that meets at a time convenient for European participants. So if any of those sound like something you might be interested in, feel free to check it out at our website, ancan.org. So without further ado, we're going to get started. If you guys will wait 1 second, I thought I had a document open and I do not. Now I'm not going to be able to find the one I want. All right, sorry about the delay. So Ronnie, one of the things we do here at AnCan, if you're brand new to our group, we let you go first. We have kind of what we call an intake form, which we ask you questions about your conditions and your diagnosis, and then we go from there. If you've got questions for us, or if we can give you any kind of peer support or advice on what's going on. So.
Well, thank you. Yeah, actually, I do. Just
well,
really briefly.
Let me get to the questions, and then we'll see what we can do for you. So first off, we ask how old you are.
I am 63.
All right, I'll be 63 this year. So we're peers there too. And you're in Pennsylvania, right?
Right, exactly. I'm like an hour and a half north of Pittsburgh.
Okay, near Pittsburgh. And are you a veteran by any chance?
I am not.
No, we just ask because we have veterans support group also. If you'd like to get our email reminders about the groups, you can put your email in the chat window, as I discussed earlier. So first off, when were you first diagnosed with prostate cancer?
February 2nd of 26.
All right, so just recently.
Yeah.
And how did this come about? Did you get a PSA test, or were you having some symptoms? You headed to the doctor?
Yeah, I was actually at my urologist. I had been visiting him to address my BPH issues, and we were talking about next steps and perhaps doing aquablation or something like that. And my PSA popped up higher than 4, and so he wanted me to do another one of those before we do anything else. So I did have a follow-up, and it went up to 5.4, and so then he sent me for an MRI. So I went down to Pittsburgh.
How soon after the 4 did you get another PSA and get to 5.4?
Let me see. The 4.6 was August of 25, and then in October of 25 it went up to 5.4. But
and you So you've been being treated for BPH, right?
Right, exactly. Yeah, just medically or through medicine through tamsulosin. But the thing is, that, now in retrospect, I look between those two dates. I had a Euroflow, so there's part of my brain that says, "Oh, maybe all that messing around in there may have aggravated the prostate, and perhaps that may have been a component." I don't know if that's
You had
wishful
a
thinking.
Euroflow between the two PSA tests?
Yes. Yeah. So I don't know. Volume 48 cc's. So I went for and I went down to the Hillman Center down in Pittsburgh. That's an excellent a place for cancer care.
You said
I had
Hillmont
my
Center?
MRI done there with contrast.
You said Hillmont Center.
Hillman, yeah, Hillman,
Hillman
HIL,
Center.
yeah, Hillman Center, right.
All right. And
Anyways,
so
so
when you went to the Hillman Center, you got an MRI first?
yes, I did.
Okay. Did you get the results from the MRI as far as did they find any lesions? Did they
They
give you
did,
a
yeah,
PIRAD score and all of those?
yeah. They found one suspicious spot lesion out of, and it was a 0.6 centimeter. He was in the right posterior peripheral area, and it had a PIRADS 4. So then my urologist said, "All right, we're not doing anything about your BPH. Now we have to
Right.
see what your what is your cancer situation." So I had a MRI or a fusion
Right.
biopsy, and he did
Was that
multiple
a tranrectal or transperineal biopsy?
transperineal. I told him I did not want a transrectal because I do have an artificial hip, and so I did not want to. Even though the percentage is fairly low, if I was the unfortunate guy, uh, then that infection would be really a problem, I think, for my hip. So,
Right.
anyways, it wasn't a problem.
So
We did
so
the
what were the results of your biopsy?
well, the biopsy. They interestingly enough, there was nothing where the MRI said there was something. So I found that was interesting. Even I said, "Did you get it?" He goes, "Yeah, I did multiple cores. There was nothing found. It was all normal tissue." I was like, "Okay."
So you had no positive cores at all from your
So
biopsy.
I did have one positive core in a completely different area.
Oh,
We did
okay.
a 12. We did a 12 core, and it was a Gleason 3+3 6 grade group 1,
Yep.
T1C,
Right.
and I should fess up right away. I have attended a couple of the active surveillance groups. Unfortunately, it's on Wednesday, and I already have a standing meeting, so this is the closest I
Okay.
could get to
Well, that's
speaking
fine. That's
to
fine.
a bunch of guys because I do have a thing that I want to ask or talk about. It's very brief.
Right. So you had a 3+3. You've been to a
Yeah,
couple of our active surveillance groups. Did they
yeah.
mention a second opinion?
They did, and I went to another urologist, but it turns out that urologist is in the same group, which I then found is not the thing that you're supposed to do.
It's we recommend that you get a second opinion from one of the nationally recognized doctors that provide these. So
Yeah, Bill, I think we're
if
talking different second opinions here. I think Ronnie's referring to second opinion medical, and you're referring to a second opinion on his biopsy.
I am, yes,
I
Ronnie,
have
what?
not had a second opinion on my biopsy.
Okay,
Other
so
than I asked the new doctor, "What do you think?" And he's like, "Yeah."
all right, so if you want information about second opinions, and can on our website, you search for second opinions, and the link to our second opinion section article that we have is in the chat window right there. You can actually just click on that, and it will open. It'll open up for you in another window, and you can
Mhm.
bookmark that, or you can note it for later if you like.
Okay,
So you
that
have
sounds
not had a second opinion on your biopsy. Have you had any other type of testing, such as genetic or a Decipher score or anything like that?
no.
Okay. And so you said you went to a second doctor. Did you have a follow-up conversation with the first doctor, or what did the second doctor say?
The first doctor said he thought it was a good idea that I have, talk to somebody else.
Yeah.
And
Or talk to
actually,
another doctor for
yeah,
medically, like Rick
another
said, versus the
urologist.
second. Yeah.
Yeah, another urologist.
All right.
And a urologist, and I really like him a lot. He actually listens to what you're saying. And I found that refreshing. He was not in a like pants on fire, I'm in a hurry and I don't really have a lot of time for you. I mean, he really did look at you and listen to, because I'm pretty methodical and I bring notes.
Right. Yeah, I would say if you could find a doctor that listens to you, that you've found a good thing. So
yeah. So so that's all that. What was it? Oh, the other thing I want to say is that it was less than 5% of the core was
less than 5% of that 0.6 centimeter.
Yeah. So I think that's important because now I thought I would throw this out, and I in a way, I guess maybe I'm just venting. I don't know. But I am having this amazingly frustrating battle with my insurance carrier, which is Cigna. And in between Cigna is another company that's supposed to be some kind of administrative, we're going to help you traverse the insurance company field, like we're in between you and the insurance company. I'm like, okay,
right.
So anyways, I was in speaking with my second urologist, and I was complaining. I says, listen, we've gone through all this big thing, we went through all of these loops, we found something that, first of all, the MRI didn't see. What the MRI suggested was not found by biopsy, and it was a fusion biopsy, so I would assume you should be able to hit the target. And then secondly, I said, now we've discovered that I have this little tiny lesion hanging around up in the anterior something or another zone.
Right.
It's a little Gleason 3+3, which everything that I've read is not something that I need to be, on fire about. And so I said, can we go back to where I started, which was to get some treatment for my BPH, because I've been on tamsulosin and I'm sick of it. I can't take it. I'm like done with it. And he said, yeah, absolutely. You're a candidate. No problem. We're going to get you to do this resume treatment. And it wasn't really my number one, but I said, you know what? At least it's something. So I can get some relief for my symptoms. I don't have to be getting up 2-3 times at night. I don't have to have the side effects of tamsulosin. I'm like, I'm all for it. And then after back and forth, I was scheduled, and then the insurance company or the in-between people said, oh no, we're still have questions. So the date of my so-called procedure came and went. Then I'm talking to them, and you get anything from, oh, well, we can't give you expeditious decision on whether or not you should be approved until you have a date. And then the hospitals were not going to give you a date until you were approved. So I did that chicken and the egg crap for a little while. And then finally, an orthopedic nurse calls me and says, oh, you're denied. I said, okay. So after all of this and all of these talking to all these dudes and these different people, I says, now you, an orthopedic nurse, is going to talk to me about why I'm, denied for urology. I said, do you know anything about this stuff? And she says, no, I don't. I'm just here to tell you that the
said an orthopedic nurse?
Yeah, an orthopedic nurse. I was like, oh, okay. Had a broken bone, I would be thrilled. So anyways, so it gets to that, and I said, all right, so why? Why I have all the criterion of someone that should be able to get, some treatment. Oh, well, because you have cancer.
Because you have cancer, yeah. So a lot of insurance companies don't want to treat you for BPH if you have a cancer diagnosis.
But that's bullshit because it's not like just because they found a lesion that has stopped happening with BPH. It's not involved with it in the urethra, from what I understand of the positioning. So what is it?
Ronnie,
I would agree with you.
We all agree. And in fact, it's one of the reasons why we're trying to rename Gleason 3+3 as a pre-cancer. And there's a lot of work going on in that right now. There was a very good article in JAMA, which I think we featured in the low risk. Did you get the low risk reminder for this meeting?
I went online and I found it because it was a meeting I could make, and it was as close to.
Okay.
Yeah, he's talking about the mailing that we do.
I'm talking
the
about the
article was linked
reminder.
there.
So
Oh, I'll make sure to put my emails in there.
yeah,
Yeah.
and if you put your email in, we'll send you this article, because there was an excellent article last week in JAMA that Howard Walensky and myself are responding to. It came from guys we know well, Matt Cooperberg, Peter Carroll, Scott Egner, and I'm blanking on his name, the fellow at Hopkins, and also Andrew Vickers, who's a statistician at Memorial Sloan Kettering. And the thrust was that we should rename prostate cancer, which we've been saying for the longest time. We actually had a poster at GU ASCO in.
We should rename 3+3 grade group 1.
No, it is grade group 1. We want to pull it back even before grade group 1. Now, we agree with you, and the problem is it's not just here. Guys are getting dinged all the time with their insurance and their life insurance, because they have this silly little lesion, which is 3+3, which ain't going to go anywhere, and all of a sudden they can't get life insurance. Anybody here been turned down for life insurance because of your cancer diagnosis? I can tell you there are guys in the active surveillance group. So I don't know what we can say. I mean, all we can tell you is we're advocating strongly. And now we're seeing this other issue where guys can't get BPH treatment because they got this silly little lesion which doesn't need treating.
Yeah. Ronnie, the only thing I would say, one course of action you might take is, like you said, you like the urologist. I don't know if you were talking about the first one or the second one, but if you could get the urologist to say this is a medically necessary procedure to relieve some health condition that you have, and that it is not caused by the 3+3 prostate cancer, that might be a way to do it. But you're going to have the doctor on your side and push for that. And he has to say it's medically necessary to relieve something else.
Right. Well, I mean, we do have next steps. I just came online this evening because I was just wondering, am I just barking up an imaginary tree here, and I just should, accept my fate of, like, this is not medicine. It's, this is political bullshit because they want to save money so they can give their CEO $23 million a year. I don't care. And if I sound bitter, it's because I sort of am. But I do have, next is, they said that my doctor can do a peer-to-peer with their urologist guy, I'm assuming. And then secondarily, I can appeal. But I was just wondering if I'm just wasting my energy. And
well, I mean, that's something that you need to decide. Is your BPH, is it affecting your quality of life? Is it something that bothers you a lot? Then it does. If you feel strongly about wanting to get it treated, then no, don't give up. If it's something that you think you can live with, that's a decision you would make, right? Right. But I know a lot. I never experienced. I was never diagnosed with it, but I mean, I first went to the doctor when I discovered my prostate cancer because of urinary issues, right? And he wanted to diagnose BPH, but we found the PSA first, a high PSA reading before he did any kind of BPH treatment. So, but yeah, I mean, if you feel strongly about it, then definitely pursue it. I mean, is it? And you say, are you wasting your time? No, you're not wasting your time if you're trying to improve your quality of life. And I mean, I know I use the TRICARE system because I'm retired military, and I know a lot of guys that have gone back to doctors. And usually, if you're getting treated at a military facility, the docs are on your side. But if you're out in the civilian world, they don't work the same way. And but you can go back and argue your point and sometimes you bring them over to your side.
Yeah. Well, I mean, I thought he was on my side because we explicitly, you know, discussed, and the way he said it to me, he says, "Look, you have two concurrent conditions. One is you have this Gleason 3.3 small lesion." I says, and he said, and then another thing that's not really related is your BPH. So let's talk
Well,
about your BPH.
that's exactly what he needs to say if he has a peer-to-peer with your insurance company's doctor.
Yeah.
Those are the exact words, and it's medically necessary to relieve your BPH symptoms.
Yeah. That's great. So that's my story.
I mean, it sounds like you already got a direction to go, and it sounds like your doctor is saying what I would ask my doctor to say to the insurance company. So,
I guess the only other question I have is, would they still have the pathology slides someplace, like
oh sure,
that I could send it some? Okay, I didn't know how long
they
it would
keep
take.
those.
Oh, okay.
You just had them done, right?
Yeah, exactly.
I asked for mine a few years after, and they keep them. So.
Oh, okay, good. I just didn't know the methodology, so I appreciate that as well. Thank you for the time. I appreciate it. Thanks, Jim.
Oh, no problem.
Anybody else have anything they'd like to say about this issue and whilst we're on it, and the renaming of 3+3? I know it doesn't affect you guys as much at this point, but it does have these side effects and these reverberations.
Yeah.
I shouldn't say side effects because they're not. No, they're not really side
Yeah,
effects.
this is and from what Rick said earlier, we didn't really discuss this part, Rick, where it for an insurance issue, right? So if they reclassify 3+3 as a precancerous condition, there was a lot of debate on whether men would worry about active surveillance or if they would, would go for further tests for PSA and things. But this is a very good point right here, the insurance thing. So Larry, you got something to say?
Yes. I dealt with the VA and bureaucracy and doctors, and I had a doctor fire me because he didn't want to give me the treatment I wanted. My advice is get your ducks in a row, do your research, be fully informed about all the issues, and press on. Don't let the insurance company deny you just because of their bureaucracy. You need treatment. You want treatment. Your doctor agrees that it's medically necessary. Don't, go for it.
All right. Anybody else want to give Ronnie some info or advice? All right, we're gonna move on. Brian in Seattle, you were the first guy in the room. You almost beat me in.
I'm always the first guy in the room. usually. I just had a question. So I had an MRI a couple weeks ago at the VA hospital. It was a PIRADS 2. It was clean. And I'm getting a biopsy at the UW, University of Washington in Seattle. I'm going to talk to the doctor there in a couple weeks and then get that biopsy. There's nothing to target though, right? With that PIRADS 2. Is that, do I need to even send the images from the VA to the UW? Or is that something I don't even need to consider? Because there is a PIRADS 2 after my aquablation. It was a PIRADS 2 a year ago, had an aquablation, and they found, 3+4, 10% 4. And I also did a Decipher of 0.91. But the last MRI I just had says PIRADS 2. So I'm just wondering if I got to do anything for that appointment for the biopsy. Finally
I would send it. I would send it along. It can't hurt.
Okay.
Because your your doctors also know how to look at MRIs, and it may inform them of something, even if it is only a 2. They may see something else that prompts them that they want to load into the machine.
Okay. Does anybody know, like Larry, do you know, is it easy to send from the VA to University of Washington? Or is that Because the VA is kind of hard to deal with sometimes, and I'm not sure how to or Bill.
Well, I can only speak to the VA down here that I don't use the VA myself, but I know the guys down here that do, and I hear from other guys in the group. I'm in St. Petersburg, Florida, which is on Tampa Bay. We've got 2 big VA centers here. But the VA hospital, if you're going there and getting treated, it's a hospital. They've got all the same systems that the civilian or the outside community care has. So they can definitely send their stuff. We gosh, I seem to recall a conversation with someone in one of the groups where they said that the VA kept their X-rays or MRIs or something in a different kind of system.
Oh, that was
And
was
it you? And it was hard to send it to the civilian side.
Yeah, they're not. Well, they weren't compatible, but then somebody else said they were compatible. So I don't know, because the VA uses a certain kind of software that's not compatible with outside hospitals. But I don't know what's true or what's not true. So
Have you asked about getting a copy?
no, not yet. I just
Because
okay.
it's pretty common, and they'll burn it onto a disc, and you can then take that disc and give it to somebody else, and they should be able to read it regardless of the software, because what they burn onto the disc is accessible as long as you just from the disc.
Stuart, maybe, because there are some institutions that won't take discs. We've run across that.
Yeah.
Because they're worried about viruses and this, that, and the other. So you got to send them digitally. So the best thing to probably do, in my view, would be call whoever is who's doing the scheduling at Hutch, and tell them that there's a record there at the VA and that you'd like that record pulled in, and let them handle it.
Okay. Even though it's only a PIRADS 2, still do it.
Yeah, like Stuart said.
PIRADS 2, according to how the VA read it. What happens if what happens if the guy at Hutch says, "Oh, it's a PIRADS 3 or a PIRADS 4"? In other words, we shouldn't be playing doctor. We should just be just like Stuart says, provide all the information. And Stuart may be right. You may be able to just carry a disc over to Hutch, but you need to verify with them first. They may say to you at Hutch, "Oh, you know what? The easiest way to do it is go get a disc," but you need to check with them first, because we can't assume that everything integrates the way we'd like it to integrate.
Yeah. Okay. Yeah. Perfect.
And just a good note to everybody in the meeting is you want all your doctors to have all the information that all your other doctors have. Really, every doctor that I use, and unfortunately, the list goes longer every year. I specifically give that electronic health record sharing permission to all the docs, and I tell my doctors that, hey, you're on my team of doctors, right? So I have a urologist, I have an endocrinologist, I have a heart doctor, I have a primary care, I have an orthopedist. So, and I want them all to know what the other ones know. The orthopedist might not care so much about what the urologist knows, but he has the information. I'm not a doctor. Maybe there's something the orthopedist sees in the urologist records and says, hey, wait a minute, we don't want to do this procedure because a hip replacement, someone just mentioned, right?
Okay, thank you. That's good. That's what I'll do then.
Larry, you lowered your hand, so I take it we said what you were going to say.
Well, yeah, but I'll reiterate. I got discs of my imaging, and it saved me probably several weeks waiting on the surgery, because from the report that the radiologist gave, it didn't give the picture of a previous surgery. I had a penile implant, and the reservoir was right up against my prostate. So that kind of ruled out a robotic prostatectomy, and I had to go for an open prostatectomy. The only reason we knew that is because my doctor was able to look at the actual images on the disc. So yeah, keep those records, and if you have to, bring your own laptop with a disc reader.
Okay. Thank you. Thank you. Thank you, Larry.
Hey, Larry, that's an excellent point. Just 1 second, guys. Unless we want to hear a cat meow all night. That's an excellent point because, for example, my mother-in-law just got an MRI and they gave her a disc, and I popped it in the computer and I was showing it to her. She thought that was amazing. But if you get to the doctor and they say our system doesn't read this, but you have your own laptop, pull it up, show it to the doctor on your laptop.
Okay. Good. Thank you.
All right. So I hope we helped.
You did. Thank you.
We're going to move on to Ignacio.
All right. Good evening, everyone. I guess I would just reintroduce myself. I don't think I've joined this group for about a year and a half. I've been active on the active surveillance group, as I see a few of you here from that group as well. What brings me here is that I had my yearly MRI. This was 3 weeks ago or so, and the results as compared to the MRI from last year. Okay, so this is all unsubstantiated because I haven't talked to my doctor quite yet. That's scheduled for June 3rd. But I can tell that things have gotten worse. What used to be a PIRATS 4 and a PIRATS 5 is now 2 PIRATS 5. There is also evidence of extracapsular extension, ECE. And there is this other component that is reported in the MRI, which is called the ADC, for the apparent diffusion coefficient. And last year, that number was borderline almost normal. In this year, it's gone down quite a bit. And what the ADC does is that it measures how clumped the cancerous cells, the tumor cells, are. So obviously, what you want is a higher coefficient of diffusion. And then on top of all that, I did a PSA on Thursday, and I got my results over the weekend, and my PSA has gone up from what was up to February was fairly consistent around 7. Now it's almost 10. It was like a 9.94 or something like that. So all these indicators, again, it's unsubstantiated, but all these indicators are concerning to me. What is mostly concerning is that, quite a few things. The first one is that I don't talk to my doctor till June 3rd, which is in another 8 or 9 or 10 days. I'm scheduled for a biopsy, and the first available time slot that they had was on the 10th of July, which is a month and a half. And although I am mentally, spiritually, emotionally coming to terms with the fact that I will probably have to have treatment, there is a spectrum, right? I don't know. I'm hoping that the treatment. Let me go back a step. I'm a huge chicken, so I don't want to do a surgery, even if it is a RA. So I am more inclined to opt for a radiation. And I consider myself extremely fortunate that I have access to the UC system, which is a COE, Center of Excellence. So I consider myself blessed in that regard. What scares me to death is that they'll say that I also need ADT. And I have heard, and seen so many horror stories about ADT that I'm hoping to be at a point that I can get away with, just SBRT, and even there, since I have access to the UC system, I I've come to learn that MRI guided SBRT is, like, supposed to be the best, state of the art. I'm in San Jose. It's offered by UCLA, which obviously is in LA, and I've come to learn also that it's that since the end of last year, it's also offered at Stanford, which for me is substantially closer, substantially more convenient. However, my insurance would only would would cover a far smaller percentage. So the way that I see things is that if I am a candidate for MRI guided SBRT, my choices are either to go to LA, and pay for travel, hotel, which I can do,
Right.
thankfully, or stay home and pay extra to go to.
Yeah. Well, I think you got to go forward with the things that you have scheduled before you would make that decision, right?
Yes.
Rick had his hand up. Rick, you're muted.
The first thing, and I mean, Stuart and some of the other people here will talk to you about the options and comparing the MRI LINAC to other treatments. But I would not be at all concerned about the fact that you can't get to see Dr. Carroll sooner and you can't get your biopsy sooner. I mean, when I was diagnosed and I was stage 3, I was told that as long as I did my treatment within 3 to 4 months, I was okay. So, fortunately, prostate cancer moves fairly slowly, and it's easy to be anxious, to get anxiety over the fact that you can't get to see the doctor sooner. But from a prostate cancer standpoint, it really doesn't make a lot of difference.
Mhm.
And my PSA went from 10 to 15 during the period that I was waiting. So I just want to put your mind at rest. There's a lot of things to be concerned about, and some of them you should be anxious about.
Mhm.
But though that's should be the least of your worries.
I don't think there's any way to test this, but a while back we put a couple of articles in our reminders about stress, the effect of stress on PSA, and the effect of some other things like sleep deprivation and vitamin D deficiency. And Dr. John Antonucci did a really good write-up on that. And there were some clinical trials, not clinical trials, but studies that showed that stress can affect your PSA. So you went from a 7 in February, and then an increase on a bad MRI, as you said, right? And then got another PSA, and it went up 3 points.
Yes.
And you were stressed all that time, right?
Well, I like to think that I'm handling it well. As I said, I'm mentally, emotionally, and spiritually, prepared to undergo treatment. So I like to think that I'm handling it well. I'm sleeping well, eating healthy.
Good. That's all important things to take care of.
But
I don't even know how you would test it, but I've heard so many anecdotal stories in these groups since I've been involved with AnCan, where they said that, hey, from the time I got my first diagnosis to another PSA before I got treatment, it went up this or this.
Right.
And I'm wondering if a lot of those rises are just something that nobody's even pointed out yet, like stress.
Well, a couple of things that I'd like to say. The first one is that what I'm finding harder upfront, is that I feel great. So there is a cognitive gap or dissonance between feeling great, having absolutely no symptoms, but yet being told that you have potentially a life-altering disease. It's like,
Yeah.
Somebody said earlier, if I had a broken leg, that'd be great. So it's like, going for treatment for something that you don't feel. And the other aspect that I find challenging is that what could happen is a spectrum. In fact, I saw a video from Dr. Scholes, and he has his pros and cons. I understand that, but he was saying that extracapsular extension is not really a big deal, so that offered me some comfort. But then the next page that I go to says, well, if you have ECE, then you're automatically T3A. So it's like, okay, which is it? Is it bad that I'll need a ADT, or is it not that big of a deal that I can get
Well,
only radiation?
Stuart's got something to add, and if it's not about ADT, I'll make some comments about ADT. So go ahead, Stuart.
No, I'm not talking about ADT. I just want to go back, Ignacio, and ask a couple of questions about, was the MRI done at the same place where the previous one was?
That's a great a question. The answer is this is my third MRI. The second at the same place. The reader was a different person. So done at the same place, but interpreted by somebody else.
Okay.
And also, I believe they were both done with the same brand and type of machine, but with different machines of the same type, right? Same brand. So
Was it done at a hospital?
UCSF. UCSF.
The MRI was done at UCSF.
The last two, yes.
Okay, because you had a 4 and a 5 before, and now they say you have 2 5s.
Yes.
How different the read is in terms of between those two may not be very much. You may be reading more into it than really is there.
That's a possibility. My niece, who is a PA for a urologist oncologist, said that these are highly subjective, and so for that reason, MRIs are not used to diagnose. It's actually biopsy. So you certainly have a point there, but all the indicators, the PIRAT, the ECE, the ADC, the PSA, all the indicators have trended in the undesirable direction.
Okay. Well, one thing is, in this case, I wouldn't do anything until I talk to the doctor, but you may very well want to get a second opinion on your MRI.
Yeah.
Depending, and reading MRIs for prostate cancer is very challenging. And you want to make sure, if it's at UCSF, it's probably read by somebody who's got reasonable experience in it. It's not like it was done, at a place in the strip mall down the block.
Right.
But in this case, depending on what they say, that second opinion may help you understand just how, get a better sense of what's really going on and how much different it really is. So that's one thing. As far as the PSA is concerned, was the PSA done
Yeah.
at through the same lab?
Yeah, the last 4 or 5 have been at the same lab, and they have steadily been around 7. But again, last one came in at a 9.94. Same lab.
And then my other question was about your previous. How long has it been since your previous biopsy, and what was your biopsy?
The last one that I had was almost 2 years ago, and it showed 7 of 14 cores positive. So at the time I had a PIRADS 4 and a PIRADS 5. The PIRADS 5 came back 3+3, and the PIRADS 4, which is now a PIRADS 5, PIRADS 4 came back 3+4 with a small percentage of 4. It was like in the order of 5% 4.
So that's why you went on. That's why you went on active surveillance.
That's right. That's right.
The indicators from the reports suggest that something may have changed, but you really want to get to that biopsy.
Yes.
Because the amount of change may be not very great, and it may be such that you're still in surveillance or you're just barely into treatment. So I wouldn't go running off and start worrying too much about ADT and getting too caught up in the whole treatment thing until we learn more, because it may be that you still don't need treatment.
That is a possibility. As I said, what the immediate future holds is a spectrum, and it could be from staying on active surveillance. Again, it's all unsubstantiated. My feeling is that the doctor will order a PSMA PET scan in addition to the biopsy. That's just my own feeling, but it's the fact that the breadth of possibilities is so wide, from the best case remaining on AS to all the way to having SBRT with ADT.
But SBRT with ADT for the conditions you have now is nowhere near the worst case scenario. Look at it that way. There's much worse, right? So you're not in a bad place, and don't worry about the time frames that you have right now. June 3rd is like right around the corner, right? It's next week. It's next week.
Right.
But what I will tell you about maybe some good news, if you have a bad scenario where you want to pursue SBRT and they want you to use ADT, you're probably not going to go on ADT like I did for 24 months. Or like Rick did for 2 years. You're going to go on ADT for 6 months. And how old are you? How old are you, if you don't mind me asking? I can't really tell from the camera.
I turned 62 a few weeks ago. So.
I would have guessed younger. Maybe my camera's blurry. I don't know.
Yeah, I'm sure it is.
No, you look younger on my camera. I'm 60. I'll be 63 this year.
Right.
I did 2 years ADT in my mid 50s. Early, I guess. I was 52. So, which was easier. I was a little bit younger, not too young, right? But I was a little bit younger, and I worked really hard at working through it, and I knew there was an end in sight. But we've had a lot of guys in these groups, both on the advanced group and other groups, that have done ADT for a much shorter period, 6 months, even 9 months. And they've said that, it was nowhere near the things that they'd been described, because it takes time for the effects for it to take effect over time.
I see.
And you might get, you might start to feel the effects near the end of the 6 months, and then you're off it and you recover. So,
Bill, can I interrupt and ask?
course.
Can I interrupt and ask David Sharp to provide his personal experience, his
Sure.
peer experience?
Sure. Yeah, Ignacio, I did 6 months of Orgovix last year. I was worried, like you, thinking about having to do it. Very dramatically, over dramatically, held up the first pill and said to my wife, "Today my life changes." Well, no, it didn't. It really didn't. I had one brief nightly hot flash,
Uh-huh.
and that was it. And
Thank you.
as long as you exercise, especially resistance training, you really won't be bothered by it if it's 6 months or less. So I wouldn't sweat it. But frankly, I think you're kind of putting the cart before the horse. All you really know right now, based on the MRI and the PSA, is what you already know, which is you need a biopsy. That's it. That's really all I would read into anything that's been measured so far and scanned so far, that you just need a biopsy. Once you get the biopsy, everything you've been thinking about with regard to the MRI will fade into history. It won't matter anymore. All that'll matter is that that biopsy result, and if you end up getting a PSMA. That's the answer. The MRI just says you need a biopsy. I wouldn't read any more into it than that.
All right. Thank you. I appreciate that, and I also appreciate the personal experience with ADT.
And also, if it comes to the needing beam, again, I was very nervous about that. I needn't have been. I finished my radiation almost a year ago, and I honestly can't tell today that I was ever treated.
Oh, really? That's great. What kind of beam did you have?
I had IMRT and brachytherapy.
Oh,
so I
both.
had quite aggressive radiation, and I'm fine. I haven't had a problem. Yeah.
Excellent. I'm happy to hear that. That's great. Thank you.
All right. Hey, Bill in Virginia, you had your hand up, but you lowered it. I know it took a while to get to you. I'm sorry.
No problem. I think David and Stuart covered it really.
Stuart stole one of my questions and David stole my comment. So
I would not mess around with getting more MRI interpretations. The biopsy will be the thing.
Mm-hmm.
Yep.
Yeah.
Larry, do you have something for Ignacio?
On the question of ADT, if you're going to be on short-term ADT and you have a choice, the HERO study, look it up, HERO study, shows the length of time it takes to recover your testosterone if you're on Orgovix versus Lupron. Talk to your doctor about making that choice. That's it.
Right. I understand that the first one, Orgovix, is preferable. Is that correct?
Definitely.
Thank you.
I only had Lupron, so I don't know about Orgovix. But if I would take David's advice for sure.
All right. Thank you, gentlemen.
Greg.
Yeah, I just would like to tell Ignacio that when I started down this road back several months ago, November, that was the thing I dreaded the most, was ADT. I really fought it. I fought it, did all the tests. It came out that I needed to do ADT. Much like Dave said, I waited to take that first pill of Orgovix. I'm on month 5 now. I have not noticed any major differences. I worried too much, I guess, and in my opinion, or my experience, I should say, I did not have side effects to any great degree. Maybe some hot flashes once in a while in the evening. I work out pretty extensively. I think that helps a lot. And I have most of my life, so that also helps. But I just wanted to relate that experience with Orgovix. I dreaded it. I fought it. And finally I said, well, I have to do this. And it was all in my mind so far. As again, I'm only in month 5. So hopefully it,
Thank you.
I just want to throw that out and let you know.
How many months are you scheduled to do, Greg?
6.
6? Well, you haven't had any side effects, and you got 1 more month left. And
Right. Yeah.
then you're going to tell us. Then you're going to tell us something happened after the 6th month, right?
Don't say that. Yeah, another 3 months or 6 more months.
Knock on wood. All right.
In my
Anyway, I
case,
just want to throw that out.
in my case, the Orgovix wore off, I would say about 2 months after I stopped taking it.
Oh, okay. Okay.
And that's one of the selling points for Orgovix. There seems to be a quicker recovery time back to your testosterone levels rising back up to fairly normal levels than on some of the other ones. And a shorter duration also seems to account for that. So, all right. So come back. Are you raising your hand, Larry?
Yes, I was going to say, if you do go on ADT, get a baseline bone density and a baseline testosterone, so that you know where you're going to come back to. And
a great
bone
point.
density, maybe it's not so important if you're going to be on short-term ADT, because it takes a while for you to start to lose bone density, but it's nice to have that piece of data.
Okay.
And exercise bolsters bone density. Don't forget that.
Now, is that the aerobic exercise or a resistant training or
both? Both, yeah. Very important.
Sounds good.
All right. Well, keep us up to date. Let us know what's going on.
Absolutely. Thank you for the time.
All right. All right. We're going to move on to Steve Koch. Steve still here?
I'm trying to get my camera on.
Yeah, here he comes.
Where's my camera?
I thought he fell asleep.
No, I've been here just trying to. What does it take? There it is. Using a new device today. All right. Hello. So, yeah, update. I've been not quite 2 months since I was last with the group. And so what is going on is next Monday, June 1st, I'm going in for my robotic laparoscopic prostatectomy at UCLA with Dr. Egener. He was one of the doctors that Rick recommended. And I appreciate that, Rick. Thank you. And so my question, and it's, well, I do want to say, Ignacio, the fact that to voluntarily do this, that when I feel fine, and whatever risks or complications could come out of surgery, I'm not sure I have my head completely around that, but with a week left to go, I don't think I'm mentally fighting this as much. So I guess my question to folks is, what do I need to do to say to doctors and nurses to advocate for myself post-surgery, to make this recovery go as smoothly as possible? I'd appreciate any wisdom and experiences from folks.
Well, can I answer that?
Yeah, I guess.
Okay, so obviously, I haven't had surgery, but as I said, my niece, she works in for what is it? Oh my goodness, words escape me. For an urologist, oncologist. So she deals with surgery patients all the time, and in fact, she told me that she believes surgery is a good or a better option to radiation. But as I said, I'm a chicken. But anyway, what she told me is that she sees a lot of men come back and say that they feel great like a week or two after surgery, and that she has to say to them, "That's fantastic. You feel great, but continue to rest. Don't retake your pre-surgery activities too soon. It's highly important that you rest, till you're completely fully recovered."
Yeah, that's an important point there is, so of course with a radical prostatectomy, you could experience urinary issues as far as like incontinence after they take the catheter out. And don't, take their advice on the recovery time. Don't try to do any kind of exercises on your own, right? Do what the doctor prescribes. Let your body heal up before you start to tackle those things. If it's going to come back by itself, it's going to come back by itself. If it doesn't, then you talk to your doctor about further I was going to say treatment, but not really treatment, but things you can do. So there's pelvic floor exercises. You go to a physical therapist for that. I actually had a worse experience. It's a long story. I had my catheter in for 10 weeks, but and just regular pelvic floor exercises weren't going to do it. I called it electroshock therapy to my roads and electrical stimulation to help with the recovery of the muscles. So that was interesting to have electrodes that close to the things you value. One of the things you value most in life. So, but yeah, so pelvic floor exercises are great, but rest, do what the doctor says. But one thing I did, which I think helped a lot, was that as much as I could, they're going to tell you to get up and move, right? So, and walking is one of the things they're going to recommend. So, as much walking as you can do, do it. I mean, if you can only walk down the driveway and back up first, and do that, and then build up and see what you can do and push it a little bit more. But don't overdo it, of course. But don't kill yourself, but walking was one of the things that I did that I think really helped a lot. So Rick, you raised your hand.
Yeah, I just wanted to mention to you, Steve, that I sent you a surgery tips package to your email just now, so you'll find good information in there. It's a little old, but there's still a lot of good stuff in there.
Thank you, Rick.
Yeah, your doctors are going to give you good advice. I'm assuming you're in good hands with Dr. Hagener for sure. So, and usually when a doctor's as well recognized as him, his staff is also an excellent staff. I mean, he got where he is because of providing the kind of service and performance that patients admire or are going to advocate for to other patients. So, and that also comes along with the staff. I mean, he can be the best doctor in the world, but if his staff treats you like crap, he's going to get a bad rating, right? So, so listen to him, listen to his staff. I always found it best to make friends with the nurses. Be they male or female nurses, just they're the ones that do all the work in a doctor's office, and just using that phrase with nurses gets you a step ahead of some other people sometimes when you recognize that and you say, I need to talk to you guys because I realize you do all the work in the office. So you're the ones that keep things running. The doctor, he just does surgery. You guys take care of everything else. So schmooze the nurses, I guess, is what I'm trying to tell you.
Okay.
Anybody else got some advice? All right, we're going to move on. So, Jim, someone going to say something? All right, Jim. I know you asked for time. I failed to highlight your name, so I skipped over you when I went to Steve. So you're next.
All right, thank you. Just kind of a quick recap. I was diagnosed in November of 24 at Thanksgiving, and I started Orgovyx at Christmas. I had a spacer inserted in January of 25, and I had 44 IMRT treatments, 26 to the pelvis generally, and 18 specifically to the prostate through February through April. My PSA and testosterone, PSA was less than 0.01 and testosterone less than 10. Starting with May of 25 all the way through May of this year. And at 18 months, at the end of June, I've been told I've been able to go off Orgovyx. During radiation, I started having diarrhea daily and had it all the way from March or April to December, when in another support group, people recommended fiber and robotic. And that stopped the diarrhea, but I still had frequency and urgency. Probably maybe 5 or 6 bowel movements a day, and having to really know where the bathrooms are. I went through a month of sucralfate enemas in February, and a month of mesalamine suppositories in March, and then April, I was not doing anything. So May, the symptoms are coming back. So I'm on fiber, and I'm going to pick up a new prescription of mesalamine tomorrow. But just kind of needing help in how to manage this, because my gastroenterologist said this is the long term, that this the damage will work on controlling symptoms, but not to expect it to heal completely.
Well, I personally have never heard someone say that their doctor told them it was permanent. If anybody else has heard that, then definitely speak up. I suffered from radiation proctitis when I had my radiation treatment, similar to yours. I had 35 treatments. I also used the suppositories, and I still take fiber. It's been 11 years. I still take fiber to this day, just regularly. What is the suppositories you said?
Mesalamine, 1,000 milligram.
Mesalamine. I'm not familiar with that one. That is not what I used. I would have remembered that, unless it's a different, like a brand name or something. David, you had your hands up. You're muted, David.
So Jim, your GI doctor has definitely taken a look inside and said, yep, it's proctitis, all right. He could see the changes.
Yes, I had a colonoscopy in January.
Has he suggested or anyone talked to you about hyperbaric oxygen? Because that actually has a good track record with proctitis.
Not yet. I have had, with the colonoscopy, there was some cautery for bleeding, but not recommended that yet.
It might be worth looking into. I know somebody who just recently underwent it, and yeah, it's a time investment. I think it was 50 sessions he went through, but it has a good track record of helping with that sort of problem that's radiation induced. Because basically what the radiation did is it damaged the blood vessels and the lining, and then they've been rebuilt, but kind of in a crazy way. And hyperbaric will stimulate the growth of new blood vessels that will hopefully reinvigorate that area. That's definitely, if I had proctitis, something I would look into.
Thank you.
Yeah, I'd endorse that. You should have that discussion. I'm concerned. I'm concerned about not so much now that you've done it and everything is fine, but that you did a colonoscopy with significant radiation proctitis. My doctor didn't allow me to get a colonoscopy for like 5 years because with the proctitis, there's a risk of a fistula from a colonoscopy. So you have to be really careful. He made me have he recommended a sigmoidoscopy, which is what I did first time, and then subsequently did a colonoscopy. And on the sigmoidoscopy, I could see the inflamed area where the radiation proctitis was. What you're going through is a little more exaggerated than most people, certainly me. I mean, I still have minor issues 17 years later, but you know, I live with them, but mine was never as extreme as what you're doing. I think if it was, I would have considered the hyperbaric treatment, and it's definitely worth discussing that with your treating team. But I think it's also worth letting your GI doc know that he should be, for a guy who has bad radiation proctitis, he needs to be talking with your radiation oncologist before he does a colonoscopy.
Ah, okay.
When you said that there was cauterization, they did cauterization with the colonoscopy. Was that like they called it like green laser or something?
I'm really not sure, and it was. Yeah. I haven't had a lot of bleeding. It's been more like spotting.
Yeah.
So he did a little bit of cautery. He didn't have to do very much, and he said that's something he can do again if the bleeding, was chronic.
He'll be happy to do it again.
The sucralfate enemas pretty well stopped the bleeding pretty quickly, but it's just been recently that there's been some spotting coming back.
Well, I'll say the same thing Rick did. I have periodic bouts even today, and it's been, like I said, it's been 11 years. Nothing as bad as when I was, suffering it during and after the radiation treatment. But yeah, I consider, and I'm not a doctor, and no one's given me this diagnosis, but I consider any of my intestinal issues that are ongoing to be caused by the radiation treatment. But in the same vein, I will say that, I'm still alive 11 years later, and doing pretty damn good. So I'll deal with it. So
well, that's pretty much the only choice, the only reasonable choice.
Yeah, I wish we had better advice for you, but I can't recall someone coming to us saying that they've had really long-term and been told that it was going to be long-term. So the hyperbaric thing, I never looked into it. David, you said it was 50 treatments. How long is each treatment?
I believe it's about an hour and a half or 2 hours. But the actual number can vary. That's just what this one guy went through that I know. But I want to pick up on something Rick said about delaying a colonoscopy after you've had radiation. I've heard different durations for that. One of my doctors said 2 years, but I bring it up only because for anybody like Ignacio or anyone else, Albert, who might be undergoing radiation in the near future, if you haven't had your every 10-year colonoscopy, if you're due for one, get it now. Get it before the radiation. And then you've got it all taken care of, and you don't have to worry about it for a very long time. Now, last year, prior to my radiation, I was actually, I was supposed to get a colonoscopy every 10 years, but my 10-year due date came in the midst of COVID, so I skipped it. And so when I finally got it last May, just a month before the radiation, I was actually 3 years late on getting that. And I was really glad I got it because they did find a precancerous polyp in there. And if I hadn't gotten it, the colonoscopy before the radiation, I really don't, I mean, it could have gone another at least a couple of years, maybe longer, before I would have done anything about that. So now's definitely, you want to get that done sooner, just like how other people are saying to get a pre-ADT testosterone test and a DEXA scan. Here's something you want to do before radiation.
I really appreciate hearing that. That was never mentioned. So I had my regularly planned scheduled colonoscopy about 2 months after radiation, and then had another one in January because of the symptoms I was having, and none of that was mentioned at any point. So I really, a little late for me, but I appreciate knowing that, and I will pass that along.
I had to muscle my way through to get that too. I had a couple of doctors say, don't worry about it. I had a couple of my doctors were unaware of the importance of getting it done ahead of time. So it's a common oversight among doctors.
Yeah, that's a good point. Thanks for bringing that up, David. Okay, so let me see. Next on my list is Anthony. You've been very patient. You hang in there. You're still with us.
Hello, everyone. And I had a PET scan done 2 weeks ago, and I had results, and I wanted to read them to see if anyone can help me with understanding them.
Okay, first I got to ask you, why'd you have a PET scan?
I was diagnosed back in March. I had my biopsy back in March, and they diagnosed me with prostate cancer. The University of Pennsylvania is the one that did the biopsy.
Yeah.
They were going to do surgery in 2 weeks until I talked to you guys to say, hey, I should go get a second advice. So I went to Fox Chase Cancer Center, and I talked to Dr. Correa, and he agreed with a biopsy, but he scheduled me for a PET scan. So, and that's why 2 weeks ago I had the PET scan. I'm going to see Dr. Correa around June 17th. He's going to give me the results and explain everything to me.
All right.
That's the update.
Yep. I just went back and looked at my notes, and I thought you were here longer ago, but yeah, it was March. And I recall I believe it was Boykin that urged you to do this. So
yes.
Yep. So I cannot interpret a PET scan. It was a PSMA PET scan?
No, it was a PET scan, skull to thigh, full body in the machine.
Okay.
What type of PET scan though?
They gave me an injection.
Yes. So what did they inject you with? That's what we're asking.
Oh,
was it an FDG PET, or was it a PSMA PET, or was it something else?
Oh yeah, GA68 PSMA.
Yep.
So it was a gallium 68 PSMA scan.
Yes.
Correct. I don't know that any of us have real expertise. We can certainly, what you're looking for is what lights up on that. The big problem with the gallium, with all of the PSMA scans, is that you don't have a reference because it's basically looking at what lights up and it's not placing that on your body. So they do a CT scan at the same time and you overlay one over the other so you can see where it is. But if you don't have any light spots lighting up, or maybe in just one area, which is probably your prostate, then you're good. But if you've got little spots all over the place on there, it ain't so good. That's a really basic interpretation, and I defer to anybody else in the room to expand on that.
I think the key word that you should be checking for is uptake. See if you can find the instances of uptake and what it's in. Okay, hopefully you won't find instances of uptake. But if you do, that's what I believe that Rick is saying.
Yeah. Those little white dots are where there is uptake. So do you have the report as well as the scans, Anthony?
Yes, yes.
And does the report indicate any uptake other than in the prostate?
No, it doesn't say uptake. When you say uptake, do you mean the cancer is in a different location in my body?
Yes. Does it say the cancers that they see anything that's suspicious for being in somewhere other than the prostate?
It does, but it just doesn't say. For example, it says in the head neck region, there is a physiological activity noted in the lacrimal glands and salivary glands in a relative.
Yeah.
So that is probably not from the prostate cancer because the salivary glands also express PSMA.
Okay.
Anything else?
It says below the diaphragm, there is a physiological activity in the liver with SUV of 11.8, spleen with SUV of 7.5, both kidneys with SUV in the 40s, small cystic lesion in right kidney posteriorly. There is no apparent soft tissue lesion, no evidence of retroperitoneal or mesenteric atopy.
Okay, well that's good news. So I would say you don't have to worry too much, and there's no evidence of anything in the bone anywhere.
No.
Okay.
The main part, the main one is I heard earlier you guys were mentioning like PIRADS lesion. PIRADS.
Yeah, but that's in reference to an MRI, not a PSMA test, not a PET scan.
Okay.
Yeah, they do report it in the PSMA, but don't get yourself bent out of shape over that. If it's in the prostate, then we know that you might possibly have cancer in the prostate, but I wouldn't get too concerned about that.
Okay,
I wouldn't. You may, but I wouldn't.
Okay. All right. Well, those are the major ones that I see here.
Yeah, I mean, what's your current Gleason score?
4+3.
4+3. So it's possible that there could be something outside, and that's why Dr. Correa ordered that report. Without seeing it, and from what you're telling me, it sounds like they haven't found anything outside of the prostate.
Okay.
But we will iterate that we're not doctors.
Right.
It'd be best to have that conversation with Dr. Correa.
Yeah, I mean, you know, I just from what you've read, we haven't even seen the report, but you know, we're not giving you that advice. But I would say that if I had a report like that, I would be sleeping well at night, unless I was Ignacio.
Okay.
Oh, Ignacio said he's sleeping well at night.
Okay.
Thank you. Somebody's listening.
I just don't. I just really don't. I'm going to get the surgery eventually, but I'm just worried about the ED. I just don't. You know, I don't want permanent ED.
Right.
And that's what I'm worried about.
So, I mean, that's a whole nother issue. It's definitely worth bringing it up. It's definitely worth a long conversation with Dr. Correa, because he's going to be very empathetic. It's really about where the cancer is in your prostate and to what extent he can save the nerves. He can do nerve sparing surgery.
Yeah.
And really, you know, that's what I would say right now, and I'll defer to anybody else. Steve, you have your hand. Is it about this very point?
No, it was kind of a aside to what Jim said. I don't have anything directly to advise Jim on. I just had this raised a question about interpreting these reports that I have a question about, but I don't need to ask it now.
So we'll come back to you. Bill will note it, and we'll definitely come back to you. But just want to stick on Anthony's issue right now. Anybody have any words of wisdom or advice for Anthony on the ED issues around surgery?
Yeah, Anthony, I looked at my notes, and when we talked before, you didn't have your biopsy report, so you knew that you had a 4+3, but you didn't know how many positive. You didn't tell us how many positive cores you had or where they were at. I mean,
right.
General information, you know, how many positive cores did you have from the biopsy?
Yeah, I have the report here, but I don't know where to find that. Like,
okay, that's fine.
I just don't know where to find it, but I have a report.
But you do know you had a 4+3.
Yes.
Okay, and how did you settle on a radical prostatectomy?
From talking to the first doctor at University of Pennsylvania, and then talking to Dr. Correa, they both seem to say the same thing, that because of my age and I'm young, I should get the surgery. But Dr. Correa, he wanted me to talk to a radiation doctor also, just to get another opinion and get it to talk to someone else. And that person actually says the same thing, that, you know, because I'm kind of young, I should get the surgery. But they did explain to me all the radiation options, and, you know, that is an option for me.
Well, like Rick said, without knowing how many positive cores and where they were,
right,
we would be guessing on whether or not a nerve sparing radical prostatectomy was a viable option. So, yeah, so that's information you have to ask Dr. Correa. So,
okay.
And I don't know these doctors. I really liked my surgeon. I really liked my surgeon. She did a nerve sparing radical prostatectomy, and it worked. Took a little while, but it worked. But when they told you were young, I was 52. You're in your 60s, I think.
Yeah, 61.
Yeah. So I don't know what they think is young or old anymore. We were having this conversation in the car the other day. My sister is just moved into her 60s, my little sister, right? And we're driving in the car, and I said, "Do you ever find yourself like commenting on another driver's driving, like saying, 'Hey, Grandpa, get out of the way,' and then you look at them and realize that you might be the same age?"
Wouldn't every surgery be a nerve sparring surgery? What they try to spare the nerves in every surgery that
No, I mean, not necessarily. There may be the cancer may be in a place where they just have to take it out, and the nerves they can't save the nerves. So the way it was explained to me, and again, I'm not a doctor, and this was just a long time ago, right? So the nerve bundles, and I say bundles, but the nerves that they're sparing are actually like they're almost like a really super thin filament, right? That is surrounding that area that they have to like kind of. It's almost like trying to take cellophane carefully off of something and letting it sit to the side while you do all this stuff, and then trying to put the cellophane back where it was. That's actually how my surgeon described it to me. And imagine how hard that is with something, right? So
yeah.
So I would add something to Anthony. We recommend people that are going in for surgery who are 4+3 that they run something called a nomogram. Usually the Memorial Sloan Kettering nomogram. I've just put that link in the chat window for you. So you can click on that and you can run it later. Now what that does, and it's arguable how accurate it is today because of things have changed, and that the nomogram is a database over 15 years or more of how people like you have fared as a result of surgery. And when I say people like you, people who have a similar Gleason grade, who have a similar PSA, who have a similar number of positive cores. So maybe someone here, you can send your report to one of the moderators here, and they can help you read it, because you'll need to know that to put it into the nomogram. But it then tells you how likely it is that you'll need follow-up radiation. And that becomes important, because if it's very likely that you need follow-up radiation, and in my own case, I was 56, and there was a 70% chance that I needed follow-up radiation, I decided I didn't want to do the surgery because I was going to have to do the radiation anyway. And so we want you to be aware how likely it is with 4+3 that you may have to do radiation even after the surgery.
And that's exactly what Dr. Correa and the radiation doctor said to me also. That even after the surgery, there's a possibility that I would have to get radiation anyway. That's
right.
Exactly.
So what we're going to do with this nomogram is quantify what it is. And if it comes back for you and it's 70%, then you may say, I don't want to roll the dice for for a 30% success. If it's the other way around, that there's a 70% chance that you'll be successful and only 30% chance, you may say, yeah, I'll roll the dice. But it's really important to run that nomogram.
Okay.
Jim, you have your hand up.
I was just going to comment. That was exactly my circumstance, talking between surgery and radiation. Of course, I'm older, but we were talking. I was diagnosed at 73, but there was a question. I'd had a hernia surgery, and there was concern about being able to get. I had some lymph node involvement with it, to get both lymph nodes and everything cleanly. I have a friend who's in his 50s, and reasonably good health, and he had a radical nerve-sparing prostatectomy early this year, and all the stars lined up perfectly for him. He's recovered from that, had no other treatment, no ADT, no radiation, just the surgery at this point, and he's doing great. So I wish you all the best, however this goes.
Okay, thank you.
And Anthony, if you need help filling it out, reach out.
Okay,
Okay.
I will.
I'll put my email in the chat window. Did I spell it right? Okay. Yep. All right. Thank you, Anthony. Steve.
Thank you, everyone.
Steve, we'll go back to you. You had
Thank you. I can save this for the end. I don't want us to go late if other people had.
actually, Anthony was
questions.
the last person I had on my list.
Okay,
So.
thank you. So 2 comments now. Part of my decision, well, I did look into that nomogram and put in the information for my biopsy course. And it indicated, because I wanted to know, if I don't get the surgery, what does that mean? If I don't do anything. And it took the life expectancy for a 68-year-old man from dying of something else was 15 years. And it made the, okay, we get heart disease, many of us. But, my parents lived much beyond age 83. So I figure genetically, I'll probably live past that point. But that the nomogram indicated if I did not do something, if I did not get treatment, and I had a Gleason score 4+3 with 80% being Gleason 4, if I didn't do something, then that 15 years would probably be the nomogram indicated that I would most likely die from the prostate cancer, which certainly metastasized before age 83. And also that the need for radiation follow-up was less than 50%, maybe about 40%. So that did motivate me to go ahead and make the treatment decision. The question I had that came up here with regard to interpreting something as complicated as an MRI or a report from a PET scan is, I know some people put those reports into something like a Chat GPT AI, and I'm wondering if other people here have done that, and what's your opinion of using those kind of resources to help you understand what all the medical information in these reports are.
I will give you my personal opinion.
Mm-hmm.
AI is here to stay. If AI is embedded in a system like reading the MRI already, which a lot of times your MRI gets read by an AI as well as a doctor. I had that happen to me on one of mine. A person read it, but it also said this was read by blah 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 AI. So I don't know what they do as far as the results from the AI versus the doctor, but that's neither here nor there. AI is going to be embedded in all this stuff. It's going to be utilized, and it can be utilized very well to do some things very well. But at this point, my own personal opinion is you can very well put your results into Chat GPT or Claude or something. But take what comes back and look at it and look at all the references that thing gave you, and then read the references. I personally would not take medical advice from an AI yet. I would use it as a tool to give me more references. So that's my personal opinion right now. Stuart?
I think what you have to be really careful about is what you're asking the AI to tell you. You're not looking for it to interpret the diagnosis. The thing that you can use it for is to ask it to explain what you're seeing if you don't understand the words. It can be very good at that because you're not asking it to interpret. Just put this paragraph into plain English. so that you can hopefully understand what that paragraph is saying better, so that you can make your own understanding of it. Don't ask the machine to tell you, how bad's my cancer. Ask the machine to tell you what the heck does that language mean.
Yeah. And that's basically what I did with, with before AI, with regular like Google search, right? I would read something and I was like, I don't know what that medical term means. So I would research it. I would Google it, right? And then half the time I was like, well, I still don't really know. Now I know what the medical term means, but I still don't know what my result is. I'm going to go to the doctor. So.
Okay.
David, you got a comment?
Yeah, I agree with what you said, Bill, and what Stuart said. When I use ChatGTP, I've written a paragraph of instructions that I tack on to whatever the question is. And I'm going to just read you that paragraph. And if you want me to, I can put it in the chat box. But I'd say, so I asked my question, whatever the medical question is. And for me, this is just a learning tool to make me a more knowledgeable patient when I go see the doctor, not, as Stuart was saying, not to help me diagnose the problem or anything, but this paragraph that I tack on says, when answering, and so these are the instructions I'm giving to ChatGTP, when answering, rely only on medically and scientifically credible sources and provide links to your sources. Double check the accuracy of the links before including them, because you've been making a lot of errors lately and inserting incorrect links. Use only PubMed.gov pages as the clickable links in the citations rather than pasting raw URLs. Avoid weaker secondary sources. Give preference to studies published in the past 7 years, especially any meta-analyses and review articles published in well-respected medical journals, but also include any older studies of notable importance. Omit all images. That's what I put in. And if I don't put that in, I get such slop that it's almost not worth asking for.
I'll take you up on that. Could you put that in the chat room?
Sure.
Thank you.
Yeah, that's an interesting that's an interesting prompt to tag on to the information that you feed in there, like the results from a PSMA or one of the other scans. Yeah, AI is only as good right now. It's still only as good as the prompt that you give it, right?
Right, and you still can't fully trust it. You really can't. And this is why I agree with what you were saying, Bill, about you got to ask for those references, those sources that it's using, and then look at those sources. Don't just go by the ChatGTP answer only.
Yep. All right. So,
Thank you.
Steven, not Steve. I'm sorry, Steve. Rick, you had your hand up.
Yeah, just something very
Apologize.
quick for Steve Koch. If you haven't had germline testing already to see if you have any inherited, you have?
I took that that PROMISE study.
Yeah,
that,
okay.
was listed here, and they looked at 28 different genes, including
Yeah,
the
you're good.
BRCAs. Yeah, so I'm good on that.
Yeah, if you've done that, that's fine. Yeah.
Thanks.
Stephen.
Okay. Stephen, one of us had you down for not wanting time, and the other one had you down for wanting time. And I apologize if you wanted time, because I'm the one that had you down for not wanting time.
Sure, I'll take some time. So I can give you a background. I've actually been on a few of the active surveillance calls, but I think I'm on the cusp of moving to a different stage of my treatments or journey here. I was diagnosed in 2021 at age 56 with 3 of my 12 cores coming back with Gleason 6s, and I was told to, relax, just keep watching it. All that was confirmed in 2022. 5 of my 12 came back with Gleason 6s. My PSA in the last year increased 4 points from an 8 to a 12. My biopsy 45 days ago came back with 9 cores positive, with 3 4+3 Gleasons. I've really just kind of kept all this in the background. Try not to focus on it. It's time to refocus. I am actually in Topeka, Kansas. We have a NCI comprehensive cancer hospital in Kansas City at the KU Medical Center. That designation is 4 years old. I don't like my my uro-oncologist at that facility. He's young, he's cocky. I'm starting to explore shopping a different surgeon. I'm leaning more towards surgery than radiation. In the back of my mind, I've always been concerned that this is something more than prostate cancer. My father died of colon rectal cancer at 52. I was 15. I've had countless colonoscopies. They all come back okay. So that's my story in a brief. I would take recommendations for good surgeons, different hospitals. I'm stunned to hear about this mammogram information this evening. I've talked to quite a few people and no one's ever given me that nugget of information. So I'll be following up on that tomorrow. I have an appointment with this oncologist that I don't like. We're going to be reviewing my PSA mini CAT scan from last week. The biopsy came back grade 3 with those 4+3 Gleason scores. So any feedback would be appreciated.
Well, the first thing I'll say is that, the fact that your father had colon cancer and you're worried about it, but you've been getting regular colonoscopies is a good way to follow up. But everything's been fine, as you said, right?
Correct. Yes. So
from what you just told us, it looks like prostate cancer, if it walks like a duck and all of those things, right? But you've never heard of the Memorial Sloan Kettering nomograms, so.
I've heard of the hospital, but no, not that test. No.
And you got Rick's link off the chat window?
I do, yes. Yeah.
Okay.
So let me just hone in on something there,
please,
Bill, before you go on. Have you had germline testing? Have you been tested to see if you've inherited any mutations?
Not germline. I did have a decipher back in 21.
No. That's something different. So the first thing you want to do tomorrow when you talk to your doc is ask him to run a germline or inherited cancer test. Really important.
I've asked that question not so many ways, and they just get really dismissive. This is not colon cancer.
Okay, so then here's the reason why. It isn't colon cancer. If your doc has any knowledge, he's aware of something called Lynch syndrome. And Lynch syndrome is a bunch of different mutations. MLH1, MSI3, MSI6, and a bunch more. And there is a strong correlation between colon cancer, prostate cancer. So it's quite possible that if your dad died young of colon and you were diagnosed young, even though you don't have colon cancer, you may have inherited the mutation. And the problem is there are other cancers too that you should be checked for. other than colon and prostate. And for women, it's even more important because there's 2 or 3 gynecological cancers that are apparent. We have several Lynchies. We actually have a special group for people with inherited cancers. So God forbid you do find out, we've got lots and lots of support. But any doctor who tells you you don't have colon cancer, so don't worry, it's rubbish. You tell them that you need to go back to school, man, directly. What about Lynch syndrome?
Or not just Lynch syndrome, but if you have any other inherited mutations or some mutations that could drive the effectiveness of a future cancer treatment.
Right.
The BRCA mutations, you know, there's considerations that you need to take if you have a BRCA mutation and you have prostate cancer.
Right. And in fact, you can refer them to the guidelines, the AUA and NCCN guidelines, where if you have a parent who's had cancer, they're supposed to test, do a germline test. Back in the day, you probably heard Steve Koch mention the PROMISE study, but that's no longer available except under very special circumstances. We used to be able to get it for free. But they'll test you, and it's just I mean, it can be a blood test, Stephen, but it's more likely it's going to be a mouth swab,
yeah, or a saliva spit test,
a saliva test, and really important. And I'm just disappointed that the University of Kansas hasn't honed in on that. It's crazy.
Yeah, I'm not happy with them. Yeah.
You said that you'd go elsewhere. Where are you thinking? How far are you willing to travel? I mean, we can send you to Dr. Egner, or we can send you to in UCLA, or we can send you to a couple of docs at UCSF. If you're willing to go to the coast, we can send you to the other coast and to people at Memorial Sloan Kettering. There are some good docs in Chicago. I'm not a huge fan of Northwestern, although there's a couple of good surgeons there, because they tend to be too scalpel happy there. But
we're thinking of the Cleveland Clinic.
It's okay. But would I go there as a first choice? Maybe. I mean, it doesn't stand out, but I can give you names. We can give you names at Cleveland Clinic. I'm not the best on urologists. I'm much better on medical oncologists and radiation oncologists, but I'm trying to think where I really like. Probably, I mean, there's a decent guy at Anschutz. That's Colorado. We could give you a name there. I'm thinking like Kansas and what's within, where the centers of excellence are within striking distance. I don't know anybody at anymore in St. Louis. But yes, we can help you if you want to go somewhere else. But I think the first steps are, you probably need treatment. You've definitely got to look at the likelihood that this could be something more. You really need to know if you're a Lynchy. Hugely important in your treatment decision.
Or if you have any inherited mutations.
Or any other inherited mutations. But the most likely would be a Lynch because of the colon cancer.
I appreciate that. I did have the Decipher test back in 2021, and I was told I was on the cusp of active surveillance at intermediate. And then, various doctors would dismiss the test. It's really a late stage, a test for people. You're too early on to have this test. So.
Well, it's not really a late stage. I mean, a lot of people get it because they use it as an indicator to how they should progress. I mean, Stuart, you want to talk about Decipher a little bit?
Yeah, Decipher is an additional piece of information that the doctors use in terms of, deciding, what makes the most sense in terms of treatment paths. It's used a lot on 3+4s, 4+3s. It what it does is it examines the DNA of the cancer. And the doctors that I've talked to, they don't swear by it as being the absolute piece of information, but it's the type of thing that can tell them whether or not it makes sense to use ADT or not, and to what level of treatment becomes necessary. Somebody here, is it Brian? Brian, you have a 0.91?
Yes, 0.91.
When somebody's got a,
Yeah, that was just
when
taken off
somebody's,
the sample, so.
and when somebody's got a very high score, it tells them that treatment is more called for and maybe slightly more aggressive. If you come back with a very low, it's it can encourage to lesser treatment or possibly surveillance. It's a good test because it's useful information. So I would be concerned, I get concerned about doctors who just dismiss it entirely.
Yeah. David, did you have something to bring up?
Yes, Stephen, did your biopsy show any cribriform or other features like that of more aggressive nature?
I'll find out tomorrow once I have an extended conversation with my doctor.
Okay. And I was going to say as well, like you, I also had a 4+3, and I did the nomogram. And while you guys were talking, I dug up my old result, and I'll just tell you what it was. And this was with a 4+3, and let's see, what else did I have? A T2A clinical tumor stage. And so my progression-free probability after a radical prostatectomy at 5 years was 47%, meaning less than a 50% chance I would make 5 years before the cancer would come back. And at 10 years, the chance that I would be perfectly fine at 10 years was only 31%. So I didn't like those odds, and I went with a pretty aggressive form of radiation as a result of that. I'm not suggesting you do that necessarily. I'm just giving you my thought process for myself. But a 31% success rate at 10 years just didn't sound that great.
Yep. Bill in Virginia, you had a comment for Stephen?
Yeah, Stephen, have you had a chance to get a second opinion on your biopsy yet from one of the recommended sources?
Thank you, Bill.
Yeah, I was going to send my slides off to Epstein, which I keep.
Definitely.
Yeah.
Definitely do that. I have a similar trajectory to you, and he had a little bit different view, and it was a little worse, to be honest with you. So I would trust his judgment over just about any other pathologist that's read my slides.
How quickly can that happen once I do put that in motion?
He'll turn it around in 2 days once he's got it.
Okay.
Usually.
Good to know.
Yeah, if he's not on vacation or speaking somewhere, which we've known to happen, but he's pretty good. And if you call that number and he's around, he usually picks up himself. So, yeah. But yeah, I was gonna say exactly the same thing as Bill.
And you know, Stephen, no one's arguing with him, whatever their age, right? He is the authority.
Interesting. Interesting. Just a nugget of news here. I follow a lot of different newsletters and support groups. I am plugged into the ASPI.org website, and like a month ago, they sent me just on an email blast to everybody a link to their new active surveillance guideline book for patients. And man, I wish I would have had that, 5 years ago. Just incredibly resourceful.
Yeah, we've just reviewed that, and we put a link to the review in the reminder this week. So
I'm taking copies and sending copies to all the doctors I've spoken with in this part of the country. Absolutely.
Now there's I've put one name in there, Maroney. There's another guy that we like a lot in Chicago, Brian Helfand. Definitely would recommend him. I mean, there's a lot of guys around that we can recommend. It's just really more a question of where you want to go. Okay. I'm trying to keep them close to. I'm trying to keep them as close as I can to where you are.
Sure.
But
I might reach out to Rick. I might reach out to you offline after the call or sometime this week, if that's all right.
Yeah, you can. I mean, I'm not sure I'm the best person because this isn't really my area. But yes, I mean, I sort of know where the docs are.
Yeah, or Bill, just to get some clarification on a few things from this call, if that's all right.
Well, I'll defer to Bill, but I'm not the follow-up person for this call because I have my hands full with the advanced guys and running the whole organization. Bill has his hands full running whatever part of the organization I don't run. But he is a moderator for this call, as is Stuart. So they're probably the people to follow up with. B. Franklin at AnCan.org or Stuart at AnCan.org.
I appreciate your help. I appreciate your insights, gentlemen. Thank you.
And Stephen, they can reach out to me if they're looking for doctors' names that they don't have. But I've put Brian Helfand. We like him a lot. I've put Maroney. We loved Egner, who was in Chicago, but he's now gone to UCLA, so he's moved on. But yeah, we can recommend names depending on where you're willing to go. And depending on whether you in fact decide on surgery, because it may be that some of these things will make you change your mind.
Right. Absolutely.
Yeah.
Absolutely.
All right. And Stephen, again, I apologize. I did not mark you down as needing time. If I had, I would have managed the time a little better. We got to you right at the end, and I apologize for that.
No worry at all. No worry at all. Thank you, gentlemen.
I am going to stop the recording, gentlemen. We are past our time, but I hope everybody had an informative meeting and was helped by AnCan, and we appreciate you attending our meetings. So thank you.